Today's topic is intravenous fluid therapy. We will briefly discuss about the physiology, strong ion difference, different type of IV fluids, therapy in different conditions, and bedside assessment of fluid status. So if you see in physiology the body water distribution, so if you take a 70 kg adult male, 42 liters will be the total body water. It will be again distributed into intracellular fluid and extracellular fluid. Like 40% of that will be in the intracellular space and 20% it is in the extracellular space. Again, extracellular space is divided into plasma and interstitial fluid. So plasma is the intravascular space which consists around 3.5 to 4 liter, and interstitial fluid which consists around 10.5 liter. We see here plasma and interstitial fluid are separated by a capillary membrane. They have small pores which allow small molecules like electrolytes and all freely permeable through this membrane. This extracellular fluid and intracellular fluid are separated by a cell membrane which does not allow free float of these electrolytes. So when we give different type of fluids, either crystalloids or dextrose water or colloids, so how it is distributed among the intracellular fluid and extracellular fluid. If we give 1 liter of dextrose 5% water, 60%, more than 60% will go into the intracellular space. Only 8%, that is 83 ml of 1 liter goes into the plasma. So it is not useful for the resuscitation as a fluid. It can be used where cellular dehydration is there. For example, like diabetic ketoacidosis or severe dehydration, starvation. In those kind of situations, we can use dextrose 5% water. If you take crystalloids, if 1 liter we give, like normal saline or Ringer's lactate, of that 1 liter, 250 ml goes into the intravascular space and 750 ml will be in the interstitium. Whereas colloids, the volume which we infuse totally goes into the intravascular space. So when we are giving fluid therapy, one should know like where the fluid is getting distributed, so that according to indication we can plan the IV fluids. So this is the same depiction in a different way. We can go through it later. So bicarbonate buffer system is the main buffer system in the blood. It plays a crucial role in maintaining acid-base balance. 2/3 of the carbon dioxide in the human body is metabolized as bicarbonate through the action of carbonic anhydrase. So the equilibrium between carbon dioxide and bicarbonate leads to the elimination of volatile acid. The bicarbonate buffer system is described by the following equation, like carbon dioxide plus water combines to form carbonic acid, and it dissociates to bicarbonate and H plus depending upon the condition. Coming to balanced solutions. So now when the fluid is called a balanced solution. So balanced solutions include crystalloids and colloids with minimal effect on hemostasis of the extracellular compartment, and in particular on acid-base equilibrium and electrolyte concentrations. Like it should maintain the electrolyte neutrality or acid-base neutrality when we give. So there are two main categories in balanced solutions. Fluid causing minimal effect on acid-base equilibrium have an electrolyte content with an in vivo strong ion difference of 24 to 29 milliequivalents, or fluid having a normal or subnormal chloride content. So balanced solutions are those solutions which have strong ion difference close to 24 to 29 milliequivalents per liter, or subnormal or normal chloride content less than 110 milliequivalents per liter. So these are termed as balanced solutions which we use on a regular basis. So the three variables regulating the pH of biological fluids independently are partial pressure of carbon dioxide, the concentration of non-volatile weak acids, and the strong ion difference. Strong ion difference is defined as the difference between the sum of strong cations and sum of all strong anions. So these principles clearly suggest that intravenous fluid may affect pH due to the specific electrolyte content. Like whichever solution we are giving, the electrolyte content in that solution and the strong ion difference of the extracellular compartment should be seen. The dilution effect due to the volume infused thus reducing the concentration of non-volatile weak acids. So recent studies clearly showed that in this regard the ideal balanced solution should have an in vivo strong ion difference equal to baseline concentration of bicarbonate, that is 24 to 29 milliequivalents. So what is strong ion difference? It is the difference between sum of all strong cations and all strong anions in the extracellular fluid. So the strong ions in the extracellular fluid are sodium, chloride, potassium, magnesium, calcium and lactate. So the strong ion difference can be determined as like sodium plus potassium, magnesium and calcium altogether minus anions, chloride and lactate. So to maintain the principle of electroneutrality, the relationship strong ion difference and the ions that dissociate from water, like it can be like a strong ion difference plus H plus OH minus should be 0. So to maintain this electroneutrality, the following equation can be given. Since OH minus has a negligible influence on H plus, the physiological pH range, the above equation can be simplified. Strong ion difference plus H plus is equal to 0, or strong ion difference is minus H plus. So strong ion difference and H plus are inversely related. So whenever the H plus ions are increasing in the body, the strong ion difference will decrease. So we have to remember this, like H plus and strong ion difference are inversely related. If we consider pH here, the pH and strong ion difference are parallelly related, like they move in same direction. Therefore, to summarize, an increase in plasma lactate concentration will decrease the strong ion difference, and this will decrease the plasma pH. The strong ion difference of plasma is normally about 40 milliequivalents per liter. If we see the difference between strong cations and strong anions, this difference is the strong ion difference. So it maintains the plasma electroneutrality. So if you see normal saline, it has a strong ion difference of 0. That means normal strong ion difference is 40 and normal saline strong ion difference is 0. So the strong ion difference, when we infuse plasma, it decreases. So when strong ion difference decreases, it decreases pH, increase H plus ions and causes acidosis. So the more difference is the strong ion difference from the baseline strong ion difference, it causes acidosis. So though normal saline is named as normal saline, it is not normal saline. So it should not be used on a regular basis. So if we see regular crystalloids which we use, normal saline, Ringer's lactate and plasmalate, you can see here strong ion difference is 0 for normal saline, 28 for Ringer lactate and 50 for plasmalate. So both Ringer lactate and plasmalate strong ion difference is near to plasma. So these two can be considered as balanced solutions, whereas normal saline, it is slightly hypotonic and strong ion difference is high, which causes metabolic acidosis when infused. So it should not be used as a maintenance fluid on a regular basis. Here we have different electrolyte concentration of different fluids, crystalloids and colloids, synthetic colloids. So if we see the strong ion difference at the bottom of this slide, almost all are near to the plasma strong ion difference. So osmolality is also near to plasma osmolality. So here NS is not included. So these are all considered as balanced salt solutions, except this sterofundin, which has a chloride content of 127, which is above the normal level. So coming to crystalloid fluids, Ringer lactate aimed to resemble the composition of the extracellular fluid. The sodium concentration, however, it is 130 millimoles per liter, which is lower than the plasma, which is 138. So a buffer is added, either lactate or acetate. If acetate is added, it is called Ringer acetate. If lactate is added, it is called Ringer lactate, to maintain a normal pH. These fluids still exert a slightly acidifying effect because of low strong ion difference. The solutions are slightly hypotonic. Used to expand ECF volume, blood loss during surgery and intensive care and routine maintenance fluids. Coming to normal saline, it is termed as isotonic, but it's slightly hypotonic compared to serum osmolality, where normal saline osmolality is around 308, that contains only sodium and chloride in equal amounts. The fluid causes slight metabolic acidosis when infused volume more than 2 liters or more. So clinically, we can give normal saline only in 2 conditions where there is a hypovolemic hyponatremia and hypochloremic metabolic alkalosis, which is caused due to excessive vomiting due to loss of H plus ions. It causes a higher dose-dependent degree of acidosis and hyperchloremia, which is possibly favors the contraction of vascular smooth muscles, potentially leading to reduced renal perfusion. So when a healthy volunteers receive 2 liter either saline or plasma light over 1 hour, saline significantly decreased the renal artery blood flow, decreased renal cortical tissue perfusion, decreased urine output, and increased extravascular fluid accumulation compared to plasma light. So these findings may support the idea that hyperchloremia may cause increased tubuloglomerular feedback and decreased renal cortical perfusion. So it is high chloride content is causing increased tubuloglomerular feedback and decreased renal cortical perfusion. Saline, hypotonic saline may also be useful in treatment of brain edema and severe hyponatremia. You see this slide again, where we are giving normal saline and ringer lactates crystallets 1 liter. 750 ml is going into the interstitium and 250 into the intravascular space. So when there is a 250 ml of blood loss, we have to give 1 liter of crystallite to compensate for that volume loss. Coming to dextrose solutions, the glucose solution is isotonic at 5% concentration, which only contains 200 kilocalories per liter. So it should not be given as a daily nutritional requirement. It only prevents starvation and does not provide adequate nutrition. So the chief indication for its use is to prevent hypoglycemia and severe muscle wasting and provide water for hydration in the intracellular fluid space. For example, in diabetic ketoacidosis, where intracellular dehydration is noted, we have to give dextrose containing solutions. Free water will go into the intracellular space and replace the volume. Cellular edema and hyperglycemia are to be watched out. For example, in brain trauma, already there will be edema in the brain, and if we give more dextrose, we are doing more harm to the brain. Like intracellular edema will increase, and so we should avoid dextrose containing solution in head trauma patients. So if you see dextrose 5 water, if you are giving 1 liter, more than 60% is going into the intracellular space, only 8%, that is 80 ml in the intravascular space. Colloid fluids, it contain water, electrolytes and macromolecule that contributes to the intravascular colloid osmotic pressure. Albumin is the chief plasma protein and is marketed for plasma volume expansion, is isotonic. It comes in 2 concentrations. One is isotonic, isooncotic, and one is hyperoncotic. Isooncotic is around 4 to 5%, whereas hyperoncotic is 20%. When we give isooncotic albumin, 4% albumin, 100 ml, it replaces the 100 ml in the intravascular space. When we give 20%, it almost volume, circulating plasma volume, it increases more than twice the infused volume. So their recommended indications, like proven indications for albumin, are like sepsis resuscitation after large volume crystallite, but only 4% albumin is recommended. Spontaneous bacterial peritonitis and hepatorenal syndrome, large volume paracentesis, ultrafiltration in patients with hypoalbumin. In all these conditions, it is recommended to give albumin. But studies are still going on, but no proven role in diuretic resistance, sepsis and cardiac surgery. Where we give albumin and we do more harm is like acute brain injury and extraperitoneal infections in patients with liver cirrhosis. It is almost contraindicated. Coming to synthetic colloids, they are like starch. It prepared from plants, expands the plasma volume as much as the infused amount. It impairs the kidney function and has been associated with use, and it has limited clinical uses. Large trials like CHEST trial and SUCCESS trial showing increased mortality and higher rate of renal replacement therapy have raised alarming conclusions regarding the safety of HES solutions. Gelatin is prepared from animals. Allergic reactions are common, impairs coagulation and derange renal function. So the synthetic colloids are not routinely recommended or not routinely given except in emergencies where to replace the intravascular volume in place of blood. Where blood is not available, we can use such solutions. Coming to intravenous fluid therapy, like intravenous fluid administration should follow the 4 Ds like drug, dosing, duration and de-escalation. Drug in the sense type of fluid, dosing, how much fluid, duration for how much time, and when to stop the IV fluids. So all should, the treating physician should know all the things, when to give and when to stop and what type of fluid to be started. Among crystalloid balanced solutions, limit acid-base alterations and chloride load should be preferred, as this likely prevents the renal dysfunction. Among colloids, albumin, the only available natural colloid, may have the beneficial effect. So 3 major indications exist for intravenous fluid administration: resuscitation, replacement and maintenance. Resuscitation fluids are to correct an intravascular volume deficit of acute hypovolemia. Replacement solutions are prescribed to correct existing or developing deficits that cannot be compensated by oral intake. Maintenance solutions are indicated in hemodynamically stable patients that are not able to drink water or order to cover their daily requirement or water or electrolytes, like in perioperative period and all. International Fluid Academy suggested an acronym for the management of fluid therapy, like ROSE concept, which suggests like resuscitation, optimization, stabilization and evacuation, which summarizes accurately dynamic approach of fluid therapy, maximizing benefits and minimizing harms. Similar acronym given by Acute Dialysis Quality Initiative, like salvage, optimization, stabilization and de-escalation. The terms and mnemonics are different, but it's almost same, both are same. ROSE and SOSD are both are same. So when we come to ROSE concept, initial R suggests for life-saving resuscitation phase. R is resuscitation phase, which focus on patient rescue and early adequate fluid management. Like if patient presents in shock, we have to administer a fluid bolus of 30 ml per kg per hour, and we have to see for the response. Second is the optimization phase with focus on organ rescue and avoiding fluid overload. So after giving the initial bolus, we have to see for the response, and we should not go on keep on giving fluids which may harm the patient. So we have to start either inotropes or some other this thing. S stands for stabilization phase, focus on organ support, late conserving fluid management, identified as consecutive negative fluid balance within first week. Evacuation phase is the organ recovery and resolving phase, resolving fluid overload with active late goal directed fluid removal and negative fluid balance. Positive fluid balance is associated with higher mortality. So once the patient recovers and is stabilized, we have to aim for goal directed fluid removal. So again, resuscitation, aim for fluid treatment in resuscitation and correction of shock with the achievement of adequate perfusion pressure. Optimization, fluid should be administered according to individual needs and reassess on regular basis. Stabilization, aim to provide water and electrolytes to replace ongoing losses and provide organ support. Evacuation, removing excess fluid, which will be frequently achieved by spontaneous diuresis. Like as the patient recovers, the body spontaneously it diureses, and although ultrafiltration and diuretics might be necessary in some patients. So this is a 1 hour bundle in a septic shock patient who presents to the hospital. Like initially it was like 3 hour and 5 hour bundle, they made it as 1 hour bundle. So all these 5 things should be done simultaneously one by one, like measure the lactate level, obtain blood cultures before administering antibiotics, administer broad spectrum antibiotics, begin to rapidly administer 30 ml per kg crystalloid or for hypotension or lactate greater than 4 millimole per liter. Apply vasopressor if hypotension during or after fluid resuscitation to maintain a mean arterial pressure of greater than 65 mm of Hg. So coming to fluid management in septic shock, so treat hypotension and elevated lactate levels. Like initial bolus of 20 to 30 ml per kg balanced crystalloids are preferred. 4% albumin acceptable alternative to crystalloid. Observe for pulmonary or systemic edema during fluid resuscitation. So we should not blindly give fluid boluses. We should also see whether how patient is responding to fluid bolus. So we have to initiate vasopressor as early as possible. First line is noradrenaline, second line vasopressin, and angiotensin 2 for severe vasodilatory shock, which is not available in India. Goals of resuscitation are mean arterial pressure should be more than 65 to 70 in a previously normotensive, like no comorbidities, like no history of hypertension. Where patient with chronic hypertension and CKD patient presenting in shock, mean arterial pressure should be maintained more than 80. Central venous oxygen saturation target should be more than 70%. And role of steroid in sepsis. Sepsis is a relative cortisol insufficiency situation. Hydrocortisone usually advised if shock doesn't resolve even with the vasopressor support. We can give 200 mg as infusion or 50 mg Q6 hourly. Fluid management in trauma. So major hemorrhage is accompanied by a unique coagulation disorder, the acute coagulopathy of trauma and shock, leading to a poor clot formation. So the endpoints are targets for HB like 10 gram, platelet count more than 15,000, 50,000, INR less than 1.5 and fibrinogen greater than 1 gram per liter generally recommended. Based on the military experience, the recommended ratio of packed red blood cells, plasma and platelets should be 1:1:1. This is in acute trauma where there is a major blood loss, where we are planning massive transfusion. We have to plan like 1:1:1. And it depends on the institutional protocols, where some institutes follow 2:1:1, where some institutes follow bedside thromboelastography and deficient factors are replaced. Fluid management in burns, like it's a standard Parkland formula, which from decades it is being followed. It's like 4 ml crystalloids per kg for total body surface area for 24 hours, half given first 8 hours. But this strategy is a little bit liberal strategy, and last decade people are experiencing a new condition called resuscitation morbidity, where the fluids are being given excessively. Complication linked to fluid overload, such as delayed wound healing, delayed recovery of gastrointestinal function like with ELS, pulmonary edema, limb compartment syndrome, orbital compartment syndrome. All these are associated with over-resuscitation with the fluid. So now new recommendation is only 2 ml per kg crystalloids for total body surface area. So routine maintenance of IV fluids are based on different factors like age, gender, weight, losses, temperature, patient comorbidities, environment in which patient is underlying disease state, additional need for nutrition and electrolyte correction. So this is a single systemic review where they studied 31,000 patients, where patient had a high fluid balance and 70% increased in mortality. So high fluid balance from first 24 hours to ICU discharge increases the risk of mortality. So how we can assess the bedside fluid status, whether patient we can give IV fluids or patient is volume overloaded. So we'll just see a few topics. This is a focus like false protocol. Focused assessment of lung sonography limited. So something is there. Acute circulatory, when patient presents to the casualty with acute circulatory failure, emergency cardiac sonography is done to rule out tamponade and pulmonary embolism. Then lung ultrasound according to blue protocol, pneumothorax should be ruled out. Once these emergencies are ruled out, patient is not having these conditions, we ultrasound blue protocol has A profile. Like A profile means patient lungs are we can give fluids. B profile means already edema is there. So A profile we can give fluids, we will give fluid and see if no clinical improvement after giving fluids, there is a development of B profile. Usually it will be a septic shock, or if clinical improvement is there, it will be a hypovolemic shock. So when there is a B profile, it usually either cardiogenic shock or pulmonary edema related. We have to rule out other causes which are causing pulmonary edema. So bedside IVC assessment. So we patient either he should be spontaneous breathing, like he should not have severe SOB, or he should be resting position and he should be calm, or he should be on controlled ventilation without any attempts on invasive ventilation. So when patient is spontaneously breathing, during inspiration the IVC collapses. When patient is on ventilator, during inspiration the IVC expands. So it comes in the opposite direction. This is because of the change in intrathoracic and intra-abdominal pressures. So either we are assessing a spontaneous breathing patient or a ventilated patient, we have to know. So based on that, if it is a spontaneous breathing patient, we have to see the collapsibility index. If he is on ventilator, we have to see the distensibility index. So we can calculate by seeing the IVC through M mode, like seeing the minimum diameter during inspiration and maximum diameter during expiration. So this will give, like if IVC collapsibility is greater than 12%, it is fluid, like we can give some fluid and see. Or IVC distensibility is greater than 18%, we can give fluids and see. If both are less than predicted, then we cannot give more fluids. This is passive leg raise test. We should have an invasive like arterial line, we have and cardiac output monitoring to accurately follow the steps. So we should give a patient head end up for 45 degrees and leg end up for 45 degrees, and we are transfusing the lower part of the body blood to the upper circulation. So when we assess the cardiac output, there should be an increase in cardiac output and increase in blood pressure. Then patient is fluid responsive. If that is not there, patient is not fluid responsive. So these are a few dynamic and static indices where we can see the fluid status, like central venous pressure, pulmonary artery occlusion pressure. We need a pulmonary artery catheter for this. Volume assessment, global end diastolic volume. It can be measured by PICO device, which is a real-time cardiac output monitor. Left ventricular end diastolic volume, which can be measured by echocardiography. And dynamic indices like pulse pressure variation, systolic pressure variation, stroke volume variation, IVC, SVC, collapsibility, all this will help in knowing the fluid status of the patient. But almost all are invasive procedure, all needs an invasive cardiac output monitor. This is the cardiac output monitor flow track called as, which gives, it monitors the arterial line by dynamic tone technology, like it analyzes the waveform of the arterial line and it gives values every 20 seconds. Like we can see cardiac output, cardiac index, stroke volume, systemic vascular resistance, stroke volume variation, and central oxygen venous saturation. Everything it will show every 20 seconds after analyzing the invasive arterial waveform. So summary of methods predicting fluid responsiveness, like bedside only we can see the fluid responsiveness by different these things like pulse pressure or stroke volume variations, but it cannot be used in a spontaneous breathing patient. patient should be on a mechanical ventilator and controlled ventilation. Inferior vena cava diameter, it can be measured, but accurately measured only in a ventilated patient with low tidal volume and lung compliance. Superior vena cava dimensions, it needs a transesophageal echocardiography. Passive leg raising, it needs real-time cardiac output monitor. And expiratory occlusion test, it needs to be patient on mechanical ventilator and controlled ventilation. Mini fluid challenge requires a precise technique for measuring cardiac output. So, conventional fluid channel like 500 ml requires direct measurement of cardiac output, can induce fluid overload if repeated. So, almost all are invasive modes of monitoring. So, conclusion, remember 4 Ds like drug, dose, duration and de-escalation of fluid therapy. 4 phases like resuscitation, optimization, stabilization and evacuation. So, key strategies: minimizing resuscitation fluids, early use of vasopressors, minimizing prescription of maintenance fluids, judicious use of diuretics and RRT to remove excess fluids play a key role. Good clinical examination, bedside assessment of cumulative fluid balance, FiO2 requirement, chest X-ray will help to switch from resuscitation to evacuation phase. So, personalized fluid therapy in critically ill patients is the need of the hour. Thank you.